this is our order for the evening. We're going to kind of go through quick definition, describe the types of spinal stenosis, describe the natural history, and then conclude with different treatments. So first of all, how much of a problem really is this? What are we really seeing generally? Well, it's relatively rare to have true symptomatic spinal stenosis. We'll discuss what that means down the road. But basically, really less than 5% of all patients that I see over a given year will have true stenosis, which would require a surgery. And again, I'll define what we mean when we talk about stenosis. There is a somewhat higher risk or likelihood of developing this among women more than men. It is a disease of middle age. And again, it's relatively rare compared to issues we see in the lower back. Neck issues tend to be a little less common, although we see it with some frequency. Well, what is the definition of spinal stenosis? Now, broadly, when we say stenosis, all we mean is narrowing. So you could have a stenotic pipe in your house. It's the same thing. You have narrowing of the tunnel of the spine, and that either manifests in narrowing at the spinal cord or narrowing of the spinal nerve. Again, I'll just describe what I mean. But ultimately, these all kind of coalesce into a constellation of symptoms which involve pain, weakness, or sensory changes. People describe numbness and tingling. They don't feel quite as strong, or pain. And I'll describe the patterns of pain and how we really can determine from the patterns of pain where the issue is. Now, what are the types? I've alluded to this already, but there really are two types of narrowing. One would be narrowing of the nerve. That would be called foraminal stenosis. The other is narrowing of the spinal cord, and that's central stenosis. So I'm going to describe what these MRIs look like. But, you know, one of the biggest things I think I could help my patients with when I see them in the office is just defining anatomy and showing them what they're looking at. I know sometimes you come in, you're like, you know, it's just a mess. And we look at, you know, I look at thousands of these. So for me, maybe I don't always remember to go through it. So, you know, I like to take my time and be as clear with this as possible. So this is what we're looking at. The image on the right is an MRI of your neck. It's a cross section. It's as if you took a slice of salami and sliced it lengthwise, and then now you're looking at the piece and you're seeing all the marbled fat and all of that. And so what we're seeing here is the disc. Hope everyone can see the arrow, but this is the disc in the front, the disc in the front. There's the bone in the back. There's the bone in the back. Spinal cord, which is in the center. Spinal cord in the center. It's surrounded by white, which is a fluid. And then you get a sense here that there are tunnels where the nerves exit from the spinal cord. Those are called your foramen. So those are the nerve tunnels as the nerves exit off the spinal cord. So spinal cord, nerve, disc herniation, and bone in the back. So let's go back to what we were referring to before. So what is foraminal stenosis? Sometimes you'll see that on an MRI report. That refers to narrowing of the nerve as it exits off the spinal cord. So it's not pressure on the cord, it's pressure on a nerve. And so that's a pinched nerve or a radiculopathy. And really what that really manifests is arm pain, arm weakness, numbness, and tingling. Alternatively, there's something called central stenosis or narrowing of the spinal cord. You can see spinal cord here is patent. There's fluid circumferentially around. It has a normal contour, which is normal oval or round. Here, there's an absence of that fluid as the cord is being compressed by a disc herniation. The difference there is that's something that is called myelopathy or spinal cord compression. That manifests, as we'll talk about later, more with gait disturbance, numbness and tingling, really spinal cord dysfunction. Now, what are the signs and symptoms of stenosis? Now, I've already mentioned that there really are two types of stenosis, each with its own clinical presentation, radiculopathy and myelopathy. I think it's important to start off by saying neck pain is a very common problem we see. What I'm talking about now with stenosis is not necessarily neck pain. People will frequently come in saying, oh, I have a disc herniation, a slip disc, a disc protrusion, a disc bulge.
None of that necessarily means that you're going to have neck pain. Neck pain is probably the most common thing we'll see as a spine surgeon in our daily practice. And as a spine surgeon, I can tell you surgery is almost never the right answer for neck pain alone in the absence of other sorts of dysfunction. We generally try to be super conservative with physical therapy, non-steroidals, and maybe even injections if absolutely needed. But generally, surgery is not a great solution for neck pain. It's very, very common to see radiographic changes, meaning maybe I'll see a disc bulge, I'll see even potentially stenosis on an MRI, which has absolutely nothing necessarily to do with neck pain. And therefore, thinking that we're going to address that one problematic level, will address the bulge, will address the protrusion, will even address the herniation, does not necessarily correlate to good outcomes with a surgery when it's designed to treat neck pain. And I think off the bat, that's important. It's important for patients to hear, and it's important to have proper education. Now, let's move now to what that pinched nerve we had talked about. Well, what's a radiculopathy, right? So it's pain, weakness, numbness, and tingling. And the reason why we're so good at treating arm symptoms as opposed to neck symptoms is because there's a very, very specific map of where nerves typically present. So if somebody comes into my office and tells me they have pain in the side of the shoulder, the side of the arm, and into their thumb and index finger, I could almost guarantee them their problem is related to a C6 nerve. And therefore, when I treat them, if I'm addressing the C6 nerve, I expect 90–95% improvement in those symptoms, either with non-operative or operative care, depending on what stage we're at. But meaning, I think if you address a targetable problem, patients do very well. Alternatively, there are lots of reasons to have neck pain, right? You can have the muscles can be affected, the ligaments can be affected, the discs, the nerves. Because there are so many potential causes, thinking that by addressing only one of them, you'll cure neck pain is somewhat unrealistic. The other thing to know is I very frequently will have patients referred to me by either shoulder surgeons or hand surgeons because there is an overlap between neck and arm symptoms. Right? So people with carpal tunnel also have numbness and tingling in their hands. People with a rotator cuff tear also have pain in their shoulder. And because of this, it's my job to make sure we do a thorough physical exam. And so every good encounter involves a good physical exam. So what are some of the things we may see? So I'm always going to test someone's sensation. Can they feel equally on both sides where I'm touching them? Is their strength symmetric? If they ask them to push off with testing their triceps, is it equal? And we test their reflexes. There are some provocative maneuvers I can do throughout as well. So to the right of your screen, you're seeing what's called the Sperling's maneuver. And we have people extend and turn their neck to the affected side. And you're basically, I know this sounds a little bit gruesome, but you're grinding the joint down onto that pinched nerve in the hope of eliciting the same type of pain which they've been describing to you. That's a very sensitive test. When that test is positive, it highly correlates with the problem related to that nerve. Well, let's now shift gears a little bit and now instead talk about myelopathy. And if you remember, I said radiculopathy involves nerve root pressure. Myelopathy alternatively involves spinal cord pressure. The significance is spinal cord problems are a little bit more problematic. Sometimes those things are not reversible, as I'll talk about, but also the constellation of symptoms are different. So people describe fine motor skills. They suddenly notice their handwriting has changed. Things are slipping out of their hands. It's hard to put on an earring. Maybe their balance is off. They've fallen more frequently. Maybe there's the sensation that they just feel drunk. It's a very different presentation. Pain may be present, but it's frequently not. And so painless weakness, painless symptoms like that alert the physician to potentially spinal cord issues. The exam for myelopathy, we may find that they can't perform a tandem gait. That what you're seeing here is the officer saying, walk in a straight line. So I have every patient do the same thing. Show me that you can walk in a straight line looking straight ahead. If you're falling to the side, that's a little bit alarming. And then hyperreflexia, meaning your reflexes are a little bit brisk. I'll do sometimes in the office, I'll test someone's reflex and give me a good, really good brisk response. And they're all excited. And in the back of my mind, I'm getting a little bit nervous, meaning is that pathologic? Some of the special tests you'll see here, something called the Babinski. You gently scrape the bottom of the foot, and if the toes splay, that's a sign of potential spinal cord issue. The Lermite sign, we have people flex their neck quickly. Sometimes they'll describe an electric sensation going down their arm. And a Hoffman's reflex, where we flick the middle finger, and sometimes you'll see an abnormal reflex where the thumb and index finger will actually flex instead. The imaging I've touched upon, but every single person who you diagnose accurately with either nerve root or spinal cord pressure absolutely needs either some sort of advanced imaging. Generally, we order an MRI that gives us the best visualization. EMG is a little bit, it's a little bit funny to talk about. There are plenty of times where we will see EMG negative exams. That means you get an EMG and it's read as quote unquote normal, and you clearly are suffering from a nerve issue. So the sensitivity is not super high. The specificity generally is, that means it's unusual to have a positive EMG in the absence of any sort of issue going on, although that may not be in the neck, that could be in the arm or somewhere else. But it's not that uncommon to see a negative EMG with positive symptoms. Same thing with the neck for myelopathy. We're looking for narrowing of the cord, which frequently we will see on MRI. I don't know if anyone has heard the term of myelomalacia. That means whitening of the spinal cord. You may find that the cord over time actually changes in color, and that reflects advanced disease. Well, what's the natural history? Will this just get better with time? Do these things need to be intervened? Well, let's start with radiculopathy, right? That's nerve root pressure. The nice thing when I see patients with a soft disc herniation from giving them a radiculopathy, pain, numbness, weakness in a specific distribution, that's a good day, right? You can pretty much assure the patient greater than 70% of people will improve over the first 6 weeks with conservative care, including physical therapy, non-steroidal anti-inflammatories, maybe plus minus injection. But soft disc herniations are very responsive to non-operative measures. Alternatively, myelopathy, where you have spinal cord compression, is a bit more serious. There, we're a little bit more aggressive, telling people that they may need to be considering a surgery. Spinal cord compression is frequently irreversible. Now, when we used to look at these, if you look at old studies from 50 years ago, the potential for recovery was less. So we were telling people the goal of surgery is to, quote, halt progression of disease. More recent studies over the past 5 to 10 years are showing that if this is caught early enough, patients can improve up to 70% of symptoms, which is significant. And it's now a benefit that I can tell my patients that I reliably expect them to improve potentially up to 70% with that type of intervention for that type of disease. Well, now let's talk about treatment, right? So many people will respond to non-operative measures, especially with radiculopathy. Well, who needs a surgery? So we talked about myelopathy, patients with weakness, balance or coordination issues, or cord signal changes. Frequently, you may be told you need a surgery, and that is probably the right decision. Radiculopathy, we certainly will try a course of non-operative care, physical therapy, medications, consideration for injections. When that fails, we will talk about a surgery. Other reasons to get it, even in the setting of root pressure, is pain which is just out of control, 8 out of 10, 9 out of 10, serious pain which we just cannot get under control, or weakness, serious weakness. I had a patient who came in this morning, she absolutely, even if I took away, even if I only had her against gravity, couldn't lift her arm. That's significant weakness. There, if you intervene early, chances of recovery are much higher than kicking the can. All right, so now you're told you need surgery. Well, what does that look like for you? Well, there are 3 types of surgery. There is posterior or back of the neck operation. There is anterior, which would mean front of the neck operation, or a combination of both. And I want to briefly go through what that would look like. So back of the neck operation. Well, when might you be told you need a back of the neck operation? Well, it's generally reserved for multi-level disease, meaning issues greater than 3 levels, which we see. There are both fusion and non-fusion or motion-preserving methods, and one or the other may be appropriate. Generally, we think of it as a bigger surgery in the sense that it does involve a bigger incision with potentially more pain than an anteriorly or front-based procedure. When we talk about front surgery, it's generally for things located at the disc level predominantly, up to 3 levels. So the image on the left here, you're seeing single level disease. The image on the right here, you're seeing multi-level disease. So both can be accomplished through anterior or front surgery, but generally it's usually more recommended for single level. Now the benefits of anterior surgery are many. It is a minimally invasive procedure with very little pain. Now, no surgery is pain-free, but pain is not a dominant feature of this type of operation. It is very successful. If you look at the literature and in my own practice, you are looking at somewhere between a 93 and 100% success rate for relief of arm greater than neck pain. And if you look at the quality adjusted life years, so in medical research, we look at quality. So it's among the most successful of those types of procedures about improving people's quality of life. Now, among anterior or front surgery, there are different types of surgery which we may be talking about. There is something called an anterior cervical decompression and fusion, that is an ACDF, where the goals are twofold. Of course, we want to relieve pain, but the secondary goal is achieving a successful fusion. And by definition, that means there will be no motion. So I want to go through what that looks like. So we make an incision in the front of the neck. It's about 1 inch or 1.5 inches. We incise the disc so that we have access to the disc. We remove the herniated portion of the disc. By removing the disc in its entirety, we then place either a bone graft, a piece of plastic, or metal, and secure it with a plate. Under those circumstances, fusion rates are approximately 90–95%. Even among the patients who don't fuse, it's very rare that someone would need a revision or a second surgery for a failure to fuse. Well, on the horizon, and what we've been seeing more and more frequently over the past 7 years, and which has been a big part of my practice, is disc replacement. So what does a disc replacement look like? Well, a disc fusion, like we talked about, is a plastic, bone, or metal spacer with a plate where the goal of the operation is failure to move. That is the goal. With a disc replacement, the goal is maintaining motion. It is a motion-preserving operation. I want to go through both procedures quickly just to talk about some of the benefits and the differences. Not everyone is an appropriate candidate for both operations, and even when you are, there are reasons to consider one versus the other. The main difference is motion. One is designed to not move, the other is designed to move. The materials can be largely the same. Outcomes are essentially equivalent. Both procedures, you expect excellent outcomes with greater than 95–97% relief of arm greater than neck symptoms. The reoperations for a disc fusion is approximately 3%. It is even fewer among people who have a total disc replacement. In my opinion, one last difference, which I think is significant, and we've done a lot of these literature reviews at Rothman, there is greater than 30 years of excellent, not good, excellent data for ACDF. There is similarly excellent data for disc replacements. However, that data is currently limited to 7 years, which means at 30 years, is it possible that there will be some mechanical failure of these devices which we could not have anticipated, similar to the quote-unquote metal-on-metal hips? Now, I don't anticipate that. We have not seen any signs that that will be the case. But if you're being hypercritical of the data, that is a limitation. This is a patient that we did 2 weeks ago, and you could see even after a 2-week visit, he had a 2-level disc replacement, and beautifully, he is moving through these discs. He has lost no motion. So if you look, in flexion, the back of the disc is open. In extension, it's closed. He's moving very nicely through this. He's happy with his result. Well, are you a candidate for a replacement? Well, you need to have signs or symptoms of radiculopathy or myelopathy like we discussed. Right now, the FDA has only approved these devices for 1 or 2 levels of disease. Of course, you have to have failed a trial of at least some measure of non-operative management. I think the biggest issue, and where I tell most people they can't have this operation, you really have to have minimal arthritis. The goal of this device is to maintain motion. You do not want to move through an arthritic joint. It would almost be like a knee replacement where you only replace half the knee, even though the entire knee is arthritic. The part that's replaced is going to feel really nice, but the part that still has arthritis is going to hurt quite a bit. So if you have a lot of arthritis and you expect to move through that arthritis, you will continue to have pain, and therefore I rarely tell people in that setting that they're an appropriate candidate. So in summary, cervical stenosis can generally be classified as either radiculopathy, which is nerve-mediated pain, or myelopathy, which is cord-mediated issues. We generally start with conservative care alone for neck pain, and in truth, for most issues, we like to initially try a course of non-operative measures. The one caveat is myelopathy, spinal cord compression. That's something I think where there's room to discuss even early operation. When non-operative measures fail, you have either anteriorly, meaning front, or posteriorly, meaning back-based options. And generally, whether it's operative or non-operative care, appropriately timed interventions generally yield good to excellent results in the vast, vast majority of our patients. Well, thank you very much. So I think maybe now the best thing to do is if Leslie can kind of tune in.
Yep, I'm here.
Let us know.
Thank you, everyone. I am going to read a few questions that were coming in so that Dr. K can get some responses over to you. Let's see. First patient says, I am scheduled for an outpatient surgical procedure called Veriflex on October 22nd, which is intended to relieve my back pain. 90% patient satisfaction. Should I be optimistic?
So, I am, to be honest, I'm not familiar with the device called Veriflex. I'm sorry to say. An outpatient procedure sounds nice. I think in general, patients, physicians, we should all be critical of data. Greater than 90% sounds amazing. I don't know if that's the surgeon's specific experience, which is actually a good sign, meaning if someone's giving you their honest data at greater than 90%, I think you take them at their word. If that is coming from the literature, meaning historical data, I think you need to look at the quality of evidence. And just to be totally honest, I can't speak towards that. I'm not sure what that procedure is. I'd be happy to talk offline though.
Will a confirmed case of advanced cervical radiculopathy lead to central stenosis in an early 60-year-old?
Leslie, can you read that to me one more time?
Absolutely. Will a confirmed case of advanced cervical radiculopathy lead to central stenosis in an early 60-year-old?
So that's actually a great question. So if what you mean by a confirmed case of radiculopathy is that it's a confirmed case of foraminal stenosis where the nerves are being pinched, then no. Right? Myelopathy is a totally different clinical scenario, and they're not necessarily a spectrum of disease. They're in fact two different clinical entities. So radiculopathy is pressure on a nerve, which has its own treatment algorithm. Myelopathy is not just advanced radiculopathy, it's actually a different process. It's pressure on the cord, which may or may not ever develop. And if it were to develop, it would develop regardless of your confirmed diagnosis of radiculopathy. So in short, I would say that answer is no.
I can't hear it. Is it best to consider surgery for advanced FS sooner than later? When the individual gets older, damage gets worse, pain increases, etc.
So these are great questions. That's another great question. So we looked recently at our data, it's about 15 years of data at Rothman among 13 spine surgeons. And what we found was for cases of radiculopathy or foraminal stenosis, which is narrowing of the nerve, patients who were operated on within the first 6 months of symptoms had better outcomes than patients that were operated on beyond 6 months. Now, having said that, I frequently will have patients, for whatever reason, who don't want surgery within the first 6 months, and they do have excellent outcomes even after. But if you're looking critically at the data, it does appear to have a statistically significant benefit, Whether that's clinically relevant or not is probably debatable, but at least statistically relevant improvement in symptoms by early versus a later operation. So generally what I recommend to my patients is the following. If we've had a discussion where they feel that they're a surgical candidate, I generally tell them once you have decided to do a surgery, you're better off doing it sooner rather than later. Now, if there are some circumstances where they can't have it, I think that's reasonable. But I think once you made that decision, you may as well go down that path. Now, if you're still, deliberating or there's more room to run in terms of non-operative care, I think that's a totally different scenario. But I think once you and your surgeon have determined that's the best course of action, I think in general, sooner is better than later.
Several questions here on the appropriate age range of patients for surgery. So what would you say the best, if there is a specific age range of your surgical patients?
So we are not ageists at the Rothman Institute, and we don't necessarily look at age as an absolute indication or contraindication to surgery. So I think it's important to look at someone's overall medical condition. I have the benefit tonight of talking about cervical or neck surgery. Neck surgery in general, at least in our hands, is a relatively fast surgery, right? Surgery is done generally within under 2 hours, almost regardless of the surgery in the neck. The recovery, you're talking about a one-night hospital stay. Most patients leave the next morning. So from kind of a burden of surgical intervention for the patient, it's on the relatively lower end of the scale. So I think if you're an appropriate candidate for any intervention, then I think you're appropriate for this. It's very rare that we rule someone out for this type of operation for age alone. Every single surgery performed at the Rothman Institute, we get a medical clearance, which involves collaboration with either a primary care physician or a physician at one of our institutions where we operate, where we need to make sure you're optimized. You need to be in the best possible condition to have your operation, whether that means you're 20 or you're 80. So age itself is not a reason to or to not have surgery. Your overall condition is, with the caveat that neck surgery in general is easier on someone's body than lower back surgery, but of course it's on a case-by-case basis.
This one is quite mouthy, so excuse me if I pronounce anything in this question wrong. Can you please explain facet and ligamentum flavum hypertrophy contributing to severe central canal stenosis and mild bilateral neural forminal stenosis?
Sure. So, you know what, actually, this might be helpful to go back a couple of slides. Let me see if I can figure this out. So, I assume we're talking about in the neck. But in the neck, the facet joints are the joints in the back of the spine which connect the levels. So there's a facet joint in the back between C2-3, C3-4, C4-5, C5-6, and so on. The facet joints themselves, as well as the ligament between them, which is called the ligamentum flavum, which is the ligament that connects the bones in the back, with arthritis will develop what's called hypertrophy. That means they've overgrown. The reason they overgrow, the body hates instability and it hates developing that arthritis. So what your body tries to do instead is really try to hunker down and form extra bone and extra ligament so that there's not that abnormal and excessive motion. The problem is, in the knee or the hip, if you form extra bone to protect yourself, okay, maybe it impinges, maybe it doesn't, maybe it hurts, maybe it doesn't. In the neck and back, you have an important structure there called the spinal cord and the spinal nerves. And when the bone or ligaments grow there, they start growing into those structures. So it grows into the nerves and into the cord. And that gives people stenosis in the neck that can manifest as either arm pain like we've discussed, numbness, tingling, or weakness, or cord issues, which are balance, spinal cord dysfunction, potentially some bowel or bladder issues. In the lower back, those symptoms are different. They're similar though. It's leg issues which are related to numbness, tingling, weakness, pain, or claudication, which is that sense of cramping, balance dysfunction. So very similar conditions, just one in the neck, one in the back. I hope that answered the question.
Thank you, Dr. K. Next one here. Total recuperation time, and what are the do's and don'ts after surgery?
Great question. So again, I'm assuming we're talking about now for neck, and I'm going to assume we're talking about an anteriorly based procedure, although I'll briefly touch on posterior or back as well. So for the front of neck procedure, you're talking about a 1 to 1.5 inch incision. Again, it is not a painful operation. What I tell people, you will experience some difficulty swallowing for the first few days to weeks. And that's because we go through the front, you're gonna have a tube in the front, and kind of with all that work, it feels funny. Sometimes people wake up, they tell me they want a steak and no issue, but I warn every patient before, expect to feel some, maybe some hoarseness, some trouble swallowing. That is a totally normal part of the operation. I tell every one of my patients, buy yourself yogurts, milkshakes, protein shakes, so that after you can stay on that liquid diet if you need to. That passes. I've never seen it be permanent, but it's pretty common to have them initially after. You're in the hospital for one night. Sometimes we do this as an outpatient for 1 or 2 levels. You then leave the next morning. Now, in terms of restrictions, if you look at the data and if you look at our own patients, for single and 2-level disease, that means you either have a 1 or 2-level surgery, we usually will just keep you in a soft collar for the first 2 weeks and then let you go. It turned out we used to keep everyone in a hard collar. When we looked at our series, it made no difference whether people were in a hard collar or soft collar or no collar. So rather than waste the money, we let people do nothing. Now, if we're in the surgery and we feel, or even pre-op, we notice that your bone may be soft and we're nervous about that bone fusing and none of the hardware failing, then we may keep you in a collar for upwards of 6 weeks. And that's, on a patient by patient basis. Now, for back of neck surgery, like I said, bigger incision, there you can expect some more pain. And that is a very normal part of healing, and it's expected. And that's pain kind of in the back of the neck and sometimes between the shoulder blades. That can linger. That can last for upwards of 6 weeks. There, we always keep someone in a collar because there we have screws in the back. It's not quite as rigid and robust fixation as from the front. There again, though, it's a one-night hospital stay, generally less than a 2-hour surgery, and you're out. In general, with all surgery, but neck the same, we want you up and walking that day. Early mobilization has been shown to improve outcomes. Other than, not going to a concert and headbanging, there are not that many restrictions after a neck surgery. It's not the lower back surgery. We definitely hold the reins on our patients more. The neck, it's normal to go side to side. We don't want you kind of twisting your head off your shoulders, but within reason, it's usually not a problem.
Thank you, Dr. K. Few of these questions obviously get a little specific. I know that patients want to ask some questions about themselves, so these may be a little too in-depth, but in summary, we have a patient who had a prior fusion of L4-5 and a laminectomy. They have been diagnosed, have major left side headaches that radiate from scapula up the neck, behind ear, and onto left eye, making me unable to do anything. Left arm pain is moderate to severe. I have strength, but lots of pain. The surgeon has indicated that cervical surgery may not fix the headaches, which are a majority of my problem. What are these symptoms consistent with in a foraminal stenosis?
So listen, ultimately that is going to be a case-by-case basis, but generally cervical headaches we used to think of as not a real thing. So patient, we'd see a patient, they'd have headaches. We almost could always tell them, listen, you might have arm symptoms, you might have neck symptoms, you might have, some of these things we've talked about with myelopathy, but generally we tried to talk patients out of surgery for headaches alone. There was at the CSRS, which is the Cervical Spine Research Society, last year in New York, someone presented their data about doing surgery for headaches alone. They claimed that in upwards of 50% of their patients, they were seeing improvements in their headaches. Now, that's a single surgeon presenting a single case series, but he's a reasonable surgeon, and I know him, and so, I take him at face value. And I will tell you anecdotally, I have had patients who have told me the same thing and they have improved. That's generally, though, for central stenosis. I mean, generally, when the cord is tight, people can get this kind of radiating headache. honestly, what you're describing there sounds a little bit like occipital neuralgia, which is pain related to the C2 nerve, where people get headaches with radiating pain to the front of the face, behind the eye, the front of the face. And that's a little bit like what it sounds like here. I think I'd have to see it to tell you for sure. But generally, I think the surgeon sounds right there. You probably are recommending it for arm, maybe neck symptoms rather than headache type symptoms.
Okay, I've been suffering with pain and myelopathy for several years and central stenosis due to car accidents. I am a healthy 48-year-old female. Will the nerves heal if I have the surgery in the next few months? I have hyperreflexing reflexes, stiffness in the neck and shoulders, and jaw pain. The surgery scares me.
So I think that's fair. And I think that's, being somewhat hesitant with surgery, I think is very normal. And I think that's healthy to have, not skepticism, but a little bit of trepidation. I think that's normal. I think that's a normal human emotion. I would tell you generally, front-based surgeries of the things we do, it's a pretty happy day when I can tell someone, especially with myelopathy, that, hey, there's this surgery. At the very least, you will get no worse than you are today and potentially improve your life significantly. And I know that, when I see them the next day after surgery, they really are in minimal pain with significant improvements in their disease. So I would tell you, if you really have a confirmed diagnosis of myelopathy, it's probably worth having a further consultation just to see what's the extent of disease, how true are these symptoms. Hyperreflexia is a bad sounding thing, and misconstellation of symptoms. And I think it's certainly worth that discussion, because the last thing you want is to be a relatively healthy younger person, 40, 50-year-old who then, kind of lets it linger, and now, you lose another level of function. And then you're looking at that surgery anyway, but you've lost a level of function.
I'm going to couple two questions in one, just to reiterate how long patients are required to wear collar roughly, and then roughly how long would someone need to stay out of work post-surgery?
So those are great questions also. So again, historically, patients were in hard collars for upwards of 6 weeks. I'd say that over the past 5 to 10 years, there's been a movement towards potentially getting patients out of collars earlier. Most people will at least put you in a soft collar for the first 1 to 2 weeks, most, for 1 to 2 levels. When I do surgery for 3 or 4 levels, I always keep someone in a hard collar for 6 weeks. For 1 to 2 levels, it's a soft collar for the first 2 weeks, and then usually no collar, unless I'm concerned about the bone quality or something in the operating room which made me concerned, and there's some reason why I want them in a hard collar for longer, but that's generally what it is. And then what was the other question? Right, and then out of work. So that's a funny question. To be honest, this is exactly what I tell all my patients. I generally tell people you should take off as long as you feel comfortable taking off from work. In reality, I've done this on one of my partners, even another surgeon, and he was back at work literally the next day. So you can go back to work very quickly. And I find that when we do these surgeries on Friday, very frequently people will go back to work on Monday. You don't have to do that, right? Like if you're the type of person who knows your body and knows that you need 6 weeks of recovery, that's fine. It also depends on your job. If you are, a steel worker, yeah, we're probably not going to let you go back to work for 6 weeks. Mostly you're going to feel fine, but mostly that you're the type of person we need to keep the reins on. If you're, a bank manager where you're in finance, well, there, as soon as you're really ready to go back, we usually let you go back. So it is dependent on kind of your own requirements and how your body generally responds to intervention.
So sorry, I'm just losing my spot here. If someone is suffering from rheumatoid arthritis, are they a good candidate for a spine surgery? Any limitations there?
So that's a good question. So the difference between rheumatoid arthritis versus osteoarthritis generally is in the extent of the ligamentous damage. So people with rheumatoid arthritis, they sometimes could have disease that is so advanced that they become hypermobile. And so when we're talking about that mobility, well, that hypermobility can cause exuberant kind of soft tissue growth, which needs to be stabilized. Technically, the operations are identical. Right? There's pressure, the pressure needs to be removed. There's instability, the instability needs to be stabilized. Nowadays, with our anti-rheumatics, we're seeing less and less of advanced disease with patients with rheumatoid arthritis, but some of our older patients who maybe missed out on that in their younger years do have some pretty significant disease, which very frequently does need to be addressed surgically. I would tell you there has been no difference if you look at our own data and the data generally among patients with either osteo or rheumatoid arthritis, assuming they have a well-performed, well-indicated surgery, they will do exactly the same.
What's the best way for a patient to go about seeing if procedures are covered by their insurance?
So that's a good question. So hopefully wherever you're going, there is some sort of finance office where there is someone who can help you with that. To be perfectly frank, there's not a whole lot of surgeons who themselves probably even know what these things cost or what they're going to cost you or them. And certainly it's a bit burdensome or onerous on the patients if you're constantly needing to call your insurance to find out how much each thing costs. Most kind of higher level practices will have someone in a financial office who can help you with that to kind of navigate what can be very kind of murky waters of the insurance companies. But more than that, I think that's probably the best advice.
And I'll just add on to Dr. K's, we do have our own billing department here. So typically, if someone has already seen a provider, if we are able to draw up some basic surgical diagnosis codes, we are able to look into some of them. But again, it's at a very basic level. You never know if any other things will be needed during surgery or what additional costs come from anesthesia or from the surgery center. So we do not have a full compilation of the costs, but obviously if we are in network with your provider and if we are able to put together kind of a basic breakdown of what some of those fees are, but unfortunately there's no way to determine what the total amount would be or what would be covered. For mild bilateral neuroforminal stenosis, do you need spine surgery or can you benefit from any non-surgical procedures?
It's a great question. So generally, for mild foraminal stenosis, if in fact it is mild, it rarely actually needs a surgery. Now, however, that doesn't mean it doesn't need intervention. And what we generally will recommend for those types of cases are physical therapy, sometimes even chiropractics, alternative modalities, and then meaning Advil, Aleve, other non-steroidal anti-inflammatories. And then you can consider injections. So there are different types of injections. It's a little bit beyond the scope of the talk now, but there are types of injections that go into the canal where the cord is. And then there are types of injections that actually go into the nerves themselves. And sometimes with mild disease, one shot of a high-dose anti-inflammatory is all you need to kind of nip that in the bud. So generally, we'll recommend non-operative care for relatively mild.